بسم الله الرحمن الرحيم والصلاة والسلام على نبينا محمد وعلى آله وصحبه أجمعين. Today we're going to talk about hemophilia. Before starting talking about hemophilia, we'll talk a little about coagulation disorders in general. Coagulation disorders may be acquired or inherited. The acquired disorders are much more common and they involve several coagulation factors, while the inherited disorders, like the hemophilia which we will talk about today, are less common and they involve only one coagulation factor at a time. So let's start talking about hemophilia. Hemophilia A in the beginning is an inherited X-linked recessive disorder characterized by factor VIII deficiency or lack of factor VIII. But there is no abnormalities in the von Willebrand factor, which has a significance which we will talk about later. The prevalence of hemophilia A is about 1 in 5,000 males. Factor VIII, what's its activity and what's its importance? Factor VIII acts as a cofactor for factor IX in the coagulation cascade, and it increases its activity by about 200,000 times. Factor VIII is carried by the von Willebrand factor, which inhibits its activity under normal conditions. And this is why we said that there are no abnormalities in the von Willebrand factor in hemophilia A. The factor VIII chromosome, or the factor VIII gene, is found on the X chromosome, and it's quite a large gene which constitutes about 0.1% of the X chromosome. There are various mutations that can lead to hemophilia A in this gene, but the most common mutation in severe cases of hemophilia is the inversion mutation. Talking about the clinical features of hemophilia A. The clinical features of hemophilia A are totally dependent upon the levels of factor VIII in the blood. The normal level of factor VIII in the blood is between 50 to 150 international units per deciliter. Severe hemophilia is characterized by a level of factor VIII less than 1 international unit per deciliter. And the clinical features that we see here are spontaneous bleeding from early life, hemarthrosis, and bleeding into muscles. Moderate hemophilia is when the level of factor VIII is between 1 and 5 international units per deciliter. And there will be severe bleeding following injuries or occasional spontaneous bleeding. Mild hemophilia is when the level of factor VIII is above 5 international units per deciliter, and in this case there will only be bad bleeding after injury or surgery, and therefore the diagnosis is usually delayed in these cases. The lab findings in hemophilia A will be a prolonged activated partial thromboplastin time and reduced level of factor VIII, of course, but the bleeding time, prothrombin time, and von Willebrand factor levels are all normal. Mortality in cases of hemophilia A. The most common cause of death in hemophilia A nowadays is cancer and heart disease, because hemophiliacs nowadays have good treatment and can have a longer life and die of normal causes just like normal patients. Having said that, hemorrhage in general and cerebral hemorrhages in particular are much more common in hemophiliacs than in other normal patients. Also, in patients who had hemophilia prior to 1986 and had blood transfusion, blood-transmitted viral infections like HIV and hepatitis C viruses are much more common. Treatment of hemophilia A. The treatment of choice in cases of hemophilia A is giving the patient recombinant factor VIII concentrate by intravenous infusions, but economical restraints has made it that not all patients can have this recombinant factor, and most get plasma-derived concentrates, particularly in developing countries. Now, in cases of bleeding, we have to intervene with treatment, and in cases of minor bleeding, the factor VIII level should be maintained or raised to between 20 and 30 international units per deciliter. In cases of severe bleeding, the factor VIII should be raised to at least 50 international units per deciliter, and in major surgery the factor VIII should be raised to 100 international units per deciliter preoperatively and maintained above 50 international units per deciliter throughout the whole surgery and until healing has occurred. Factor VIII has a half-life of 12 hours, and therefore it should be administered twice daily to maintain attain these therapeutic levels that we talked about. Furthermore, prophylactic management of patients, so not in cases of bleeding, but in cases of prophylactic, we want to prevent the bleeding from occurring. So patients with severe hemophilia are given prophylactic management, and this is by giving them factor 8 infusions, whether recombinant or plasma derived, regularly 3 times per week. Also, there is another mode of treatment, which is giving desmopressin, which is a synthetic vasopressin, and desmopressin has shown to produce a 3 to 5-fold increase in factor 8, and this is useful for treating mild hemophilia. Like we said above, the level of factor 8 is above 5 international units per deciliter, and also before minor surgery. But in cases of severe hemophilia, desmopressin is not used. Complications of hemophilia A. The complication associated with treatment is development of antibodies to factor 8, and this happens in about 30% of people with severe hemophilia. And management of such patients is very difficult, because even when given high doses of factor 8, there may not be an increase in the level of factor 8 to the level that we need, because these antibodies will attack the factor 8 and abolish it. So sometimes the treatment is by giving factor 7, which enhances the extrinsic pathway, and giving high levels of factor 7 has shown to be therapeutic in about 80% of patients who have this complication. The long-term aim of the management is to eradicate the antibodies against the factor 8, and this is done sometimes by immune tolerance induction or by immunosuppression. The other complication that we already talked about is the increased risk of transfusion-related viral infections like hepatitis B, hepatitis C, and HIV. And this is mostly in countries that do not screen the blood, and in prior to 1986, people who had hemophilia before screening tests were available. Hemophilia B. Hemophilia B is also an X-linked recessive disorder, just like hemophilia A, but the factor deficient here is factor 9, not factor 8, and it occurs less, or it is less prevalent than hemophilia A, with about 1 in 30,000 males affected. The clinical features of hemophilia B are similar or same to the hemophilia A, and it is treated with recombinant factor 9 or factor 9 concentrates from the plasma, just like with hemophilia A, which we said recombinant factor 8 or factor 8 derived from plasma. But here, desmopressin or synthetic vasopressin is not effective, because desmopressin increases the level of factor 8 and not factor 9. So we've reached the end of our presentation. It was presented to you by me, Abdurrahman Abdullah Al-Ghamdi, and it was done by my colleagues and I. As you can see, our names here. Thank you for watching, and I hope that you have benefited.